Hello, everybody. Happy Monday. We don't normally have a What's New on a Monday. And I haven't introduced a What's New talk in the last couple of months, I don't think. So just to remind you, my name is Annabelle Mead. I'm the Program Director for the Addiction Medicine Fellowship Program at the BCCSU. And it's my great pleasure to introduce today Dr. Allison Marmel, who's one of our family practice fellows, more than halfway through her training year now, on the home stretch. She is a graduate from the McMaster Family Medicine Residency Program in Hamilton, Ontario. She's passionate about patient advocacy for vulnerable populations, particularly in the context of addictions. Through the fellowship, she hopes to further her skills in supporting patients through the recovery process. In the future, Dr. Marmel hopes to help improve access to treatment for substance use disorders in low resource settings, such as correctional institutions and rural areas. So I'm really pleased today that she's presenting on this great topic of substance use in the correctional setting. Welcome, Allison.
Hi, everyone. Thanks for coming today. So like Annabelle said, I'm going to be talking about substance use disorders within correctional facilities today. So before I start, I just want to respectfully acknowledge that I'm a humble guest on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. This is just a little bit of an outline about what I'm going to be talking about today. So the first thing I'm going to talk about is a brief overview of the health status of incarcerated individuals within Canada. And then I'll be focusing a little bit more on substance use disorders within corrections, talking about the pharmacologic and non-pharmacologic interventions that exist, and focusing on opioid use disorder in particular. The next thing I'll be speaking about is harm reduction in prison in Canada and what currently exists and does not exist. And then I'll speak in depth a little bit about prison needle and syringe programs. The last thing that I'll be talking about is how we can best support people being released from incarceration when they're released, as most of us won't be working in corrections, but certainly we'll be seeing people that have been within the system at some point. So I wanted to start off just talking a little bit about how I chose this topic. And so I think as addiction providers, because of the way addictions is criminalized in our society, many of us will see people that have been involved within the correction system at some point. And so I think that it's very important for us to be familiar with it to some degree. Something else that led me to choosing this topic and becoming interested in it was an experience I had back in my residency program in Ontario. So I was seeing a client at a clinic who was presenting 3 days after being released from prison, asking for a Suboxone prescription. He had actually been followed by our clinic prior and was actually doing pretty well on Suboxone prior to getting arrested. Unfortunately, then he went into a correctional facility. He was kept on a Suboxone for a few months of the sentence, but he reported that during his sentence, there was concerns about diversion of Suboxone on his unit. He reported that he had nothing to do with that, but despite this, was tapered off his Suboxone quite quickly over a period of 6 days. And I think predictably so, he developed significant withdrawal and cravings. And because substances are available within the correction system, he relapsed to using fentanyl. And so he used for the rest of his stay because he didn't have access to opiate agonist therapy. And then 3 days after being released, he was back at our clinic trying to get back on his Suboxone. So I think stories like that made me feel that there's a lot we can do to improve care for people who have addictions within the correction system. So this is a photo here of North Fraser Pretrial, which is a provincial facility out in Port Coquitlam. And I had the opportunity to spend a few weeks there during my fellowship a few months ago. And it was really interesting to be able to see how healthcare is provided, how addictions care is provided within provincial corrections. And I was happy to know that they're not doing things like tapering off people from their opiate agonist therapy, and their BC Corrections is making a lot of efforts to try and improve access to these medications. So just to review some terminology before I continue that I'll be using in the talk. So provincial facilities refer to places where people are kept for sentences less than 2 years. And the people that provide healthcare for provincial facilities varies across Canada depending on the province. But in BC, the Provincial Health Services Authority, or the PHSA, provides healthcare for all provincial facilities. Just a few years ago, it was actually provided by a private contractor. So it really depends which province you're in, who's providing the healthcare for those facilities. Federal facilities, on the other hand, are places where people remain for sentences 2 years and greater. And their healthcare is provided separately through Correctional Service Canada. Remand facilities refer to places where people are awaiting sentencing. So this could be anywhere from overnight to many months. And these are for individuals felt to be too high risk to be waiting in the community, or for those who can't afford bail. And often the remand facilities are combined with the provincial facilities as well, such as in North Fraser pretrial. I think a really important thing to know about incarceration is that it's extremely transient. So this is data from 2017 and 2018. And people awaiting trial, over half spend 1 week or less in the facility, and 3/4 were there for less than a month. In provincial facilities, so people serving provincial sentences, 1/3 were there for 1 week or less, and 2/3 were there for 1 month or less. And people are often revolving in and out of the correctional system, as they might get released and then be on probation and then breach their conditions and then end up back in the facility. So very transient. Also, release from court can be extremely unpredictable. So someone might have court one day, not be expecting to be released into the community, and then find out that they will be released, but not have that much time to prepare for that. And so it makes it very challenging to provide healthcare for these individuals. Something else that's really important to know is that marginalized populations are extremely overrepresented within Canadian corrections. So there's a disproportionate amount of Black Canadians within Canadian correctional facilities, and an extremely disproportionate amount of Aboriginal adults within Canadian corrections. And this is even worse for Aboriginal women. A significant proportion of Aboriginal adults that are in federal facilities have actually attended residential schools. Another alarming number is that 50% of people within correction facilities report being victims of childhood abuse at some point. And a study of Toronto jails found that 1/5 of people within corrections were homeless at the time of admission. So extremely vulnerable populations that are ending up within corrections. People in corrections also have complex health needs. So they have significant amount of psychiatric disorders. So 70%, when they've studied it, have an active psychiatric disorder. 50% have substance use disorders, with lifetime rates as high as 70%. A significant proportion of people also have had a traumatic brain injury at some point. And they also have increased rates of chronic pain, chronic disease, and lower rates of age-appropriate cancer screening. In terms of hepatitis C and HIV, hepatitis C is 30 times higher for people within corrections compared to the general population. And HIV is 10 times higher within corrections. So given that there's all these complex healthcare needs of these individuals, what's actually available within corrections? And so here I've just listed some of the things that are available. This is in general what you'd expect at a provincial corrections facility within BC, and this is what I experienced when I was in North Fraser pretrial a few months ago. And so there typically is a primary care physician who's there Monday to Friday, daytime hours, that's seeing a high volume of patients, as there's lots of complex healthcare needs, and people are often coming in straight from the streets, not having seen a provider in a long time. There's typically also an on-call physician 24 hours for sort of semi-urgent issues, but any real emergent issues need to be referred to a local hospital. They also have, all the facilities have psychiatrists that come in, psychologists, they have nurses, as well as in BC Corrections, all facilities have an opiate agonist therapy nurse. They have dentists that come in, and then they also have healthcare units where people with higher healthcare needs can be separated from the rest of the population. So overall, incarcerated individuals have higher rates of psychiatric conditions, substance use disorders, chronic health conditions, and bloodborne diseases. Incarceration is also extremely transient, so this makes it very challenging to provide healthcare and continuity of care upon release. So honing in now a little bit more closely on substance use disorders within incarcerated individuals. So like I said before, when they've studied it, they've shown that 50% of incarcerated individuals within Canada have an active substance use disorder. In terms of illicit substance use in custody, significant proportions of people report that they have used while they're in custody. And a significant proportion of the people that have used have injected. And alarming amounts of people that are injecting have shared needles. And they also report sharing with people that have known HIV or hepatitis C infections. So certainly all facilities have security measures to try and prevent substances and other contraband from entering the facility, but a lot of these are imperfect, and there are a lot of creative ways in which substances can come into facilities. And this will be the reality as long as there is a demand. Focusing a little bit more on opioid use disorder now. So in provincial corrections, 40% of people report that they've used opioids within the year prior to incarceration. And when they've studied overdose deaths after release, they found that people recently released have a 12 times higher risk of death due to drug overdose than the general population. They found that 10% of all drug overdose in adults are actually related to release from incarceration. And 20% of these deaths occur within the first week from release. And so one of the reasons why we think this is such a high risk period is the idea of tolerance and loss of tolerance. So tolerance is the idea that when you're using a substance for a long time, your body gets used to it and then you need more and more to get the same effect. When someone uses relatively less or is abstinent, such as perhaps in corrections, they lose that tolerance. And so when they're released, if someone was going to go back to using the same amount, expecting that they can tolerate the same amount as they were using prior to coming into corrections, they're at much higher risk of overdose and death. So another thing to point out is that overdoses do happen within correctional facilities, and the vast majority of these overdoses are due to opioids. Drumheller Institution, which is a federal facility in Alberta, had the highest number of overdose incidents, and I'll talk a little bit later about what they've been doing to try and mitigate that. So what's actually available for treatment of opioid use disorder within BC corrections? So this isn't within provincial corrections. Methadone and Suboxone have been available for many years. Previous data has shown fairly low amounts of people with active opioid use disorders are actually on opiate agonist therapy. And so access has been limited in the past. Luckily, it seems that the Provincial Health Authority has actually been trying really hard to improve access to these medications for people in corrections. And currently, 35% of all incarcerated men and women within provincial corrections are now on some sort of opiate agonist therapy medication. The most recent data that I could find from federal corrections, this number is actually still quite low compared to what we might expect. And a medication called Sublocade has become recently available in federal corrections and probably soon within provincial corrections. So this is a long-acting injectable form of buprenorphine or Suboxone. So people just have to get a monthly injection. And so this might be very helpful, and it can reduce the burden for the daily witness ingestion that they do, and then also can be very helpful for people perhaps receiving it just before release. So certainly there's been issues in the past and still currently about people having access to their medications. So people dealing with delayed starts, so waiting several days before they can start on their opiate agonist therapy despite being on it in the community. And as I mentioned before, in the past, concerns about tapering off these medications if they're found to be diverting it. So BC Corrections is trying their best to try and improve access and optimize treatment for individuals within corrections. So they do have a physician on call that can continue someone's opiate agonist therapy if they're on it already in the community. They also have the ability to have their nurses start Suboxone on their own if a client is in adequate withdrawal and it's safe to do so. Clients, however, must see a physician prior to starting methadone or Arcadian, which makes sense because there's more factors that you need to think about. And typically, clients will be seen every 7 days, which is potentially less frequently than what we would do in the community. And so people might take a little bit longer to reach a therapeutic dose of their opiate agonist therapy compared to the community. So in terms of concerns about diversion, it's good to know that having someone tapered off their opiate agonist therapy is not standard of care within BC Corrections, and they really emphasize using other disciplinary actions and other methods to try and reduce this. And they really reinforce keeping people on their essential medications, such as opiate agonist therapy. In terms of psychosocial treatment for people with substance use disorder in corrections, all BC Corrections facilities have a master's level addiction counselor, and they also hold something called the Matrix program, which is group therapy. It runs for 16 weeks, but they also have modified versions for people that aren't within the facility for that long. And they focus on relapse prevention and psychosocial interventions. They also run seeking safety groups, and this is a therapy model for people that suffer from concurrent trauma and substance use disorders. Another really interesting and exciting initiative is something called Guthrie House, which is a therapeutic community located within the Nanaimo Correctional Center on the island. So this is an inpatient treatment program that people can attend while they're serving their sentences. And they focus on peer leadership, behavioral therapy, and trying to help people gain skills to be able to reintegrate into the community once they're released. And when they've studied this program, they found that people that have completed the program are less likely to reoffend. And for those that have completed the program that do reoffend, it's often less severe and less often. And I believe this is the only program of its sort within Canada. So BC Corrections has been working to try and improve continuity of care due to knowing how high of a risk the period after release is. So there is the ability for some people, if they're interested, to be transferred to a recovery house or a residential treatment center upon release from a correctional facility. They also have instituted opiate agonist therapy nurses whose job is specifically to help coordinate community prescriptions. And something that people might not know about is that if someone's released unexpectedly into the community without an opiate agonist therapy prescription, and they had one that they were receiving while they were in corrections, they can actually present to any pharmacist within BC. They can tell them which facility they were being released from, and then the pharmacist can contact that facility and then get a bridging prescription. So something certainly to reinforce to people that might be able to make use for that program. BC Corrections has also started another initiative called Community Transition Teams. So this would consist of a peer support worker and a social worker. And the goal is really to help people during that high risk period right after release. So far, they've had no overdose deaths for the people that are part of the program. And the BCCSU is planning to do a formal evaluation of this program to see what the benefits are and to see whether it should be expanded. So overall, treatment of opioid use disorder during incarceration is improving in BC. Certainly there is definitely room for continued improvement to reduce delays and also perhaps allow faster titration so people can get to therapeutic doses more quickly. And community transition teams is potentially a very exciting model to help improve continuity of care and support for these individuals upon release. So I'm just going to shift gears a little bit and now talk about harm reduction within corrections. So this is a list of what's available within federal corrections. And I should note that they do list having access to bleach as a harm reduction strategy. And I guess the intention of that would be to clean syringes or sterilize them before using them or sharing them. But this is not really an evidence-based way of preventing HIV and hepatitis C infections, but it is still listed as a harm reduction strategy. Needle and syringe programs, as well as an overdose prevention site, have recently been introduced within federal corrections, and I'll speak more to that in a minute. So before I get into talking more about prison needle and syringe programs, I just wanted to review what we know about community needle and syringe programs. And so we know needle sharing accounts for a large proportion of new HIV and hepatitis C infections. And we know that community needle and syringe programs reduce needle sharing, and they help prevent new HIV and hepatitis C as well as other bloodborne infections. And it's a widely adopted and accepted harm reduction strategy that's available throughout the world. Despite quite a bit of support for community needle and syringe programs in Canada as well, prison needle and syringe programs are extremely controversial. So in June 2018, federal corrections introduced the first prison needle and syringe programs in North America. And currently there are no prison needle and syringe programs within provincial corrections. So the United Nations has standards for care for prisoners. And the principle of equivalence of care states that people who are incarcerated should have the same standards of health care that's available in the community. And they should not be discriminated against on the grounds of their legal status. And so really this should include adequate bloodborne disease prevention, such as sterile needles. This is an example of a syringe created from a pen from someone while they were incarcerated. This is an example of what people have to do because they don't have access to sterile needles. And so I hope we all agree that it's certainly a human right for all individuals, including people within corrections, to receive the same healthcare that would be available in the community. Another important thing to consider is that the vast majority of people within corrections will be going back into the community at some point, and so their health also becomes a public health issue as well. And so the fact that needle and syringe programs are not available widely leads people to sharing, and this puts people in very high risk situations. So I'll speak a little bit more about what we know about prison needle and syringe programs and some of the history. The first one was in 1992 in Switzerland. And what actually happened was there was a physician there that was realizing that people were injecting substances while in prison. And because he knew that they did not have a sterile needle program, he realized they must be sharing or using non-sterile needles. And so what he did was sort of under the table started handing out sterile supplies to his clients. And then when his warden found out, instead of shutting it down, they actually realized that there's definitely a use for that, and they decided to expand it in their facility. Since then, it's been expanded to several facilities within Switzerland, and there's programs that exist across Europe and Asia, and now most recently in Canada. So from over 25 years of data, we know that prison needle and syringe programs reduce needle sharing, they reduce injection-related infections, they reduce overdoses, and they actually have shown to increase referrals to drug treatment. And we've also seen reduction in prevalence of HIV and Hep C in the facilities that have introduced these programs. There's a few different types of models that have been used in the places that have implemented these programs. The first type of model is a syringe dispensing machine. So this was pictured on my previous slide. Basically, someone would have a syringe and then they would go up to a machine and then exchange it for a new one. This type of model is nice because if the machine is placed in a discrete area in the prison, then it allows a high level of anonymity. And so it's probably acceptable to a lot of people. Another type of program that's been implemented is hand-to-hand distribution by prison healthcare staff. But this might work in some scenarios, but some people might be reluctant to use it as it's not anonymous. Other programs have used NGOs to distribute their sterile supplies. So this is another potential model that could be used, but there might be some limitations with this as they're limited on how often they can actually come into the facility. And the last type of model that's being used around the world is a prison peer worker distribution model. And so people tend to have, or people while they're serving their sentences tend to have little jobs around the corrections facilities. And so one of the jobs might be handing out harm reduction supplies. So certainly prison needle and syringe programs are quite controversial. And I can understand that people want to make sure that safety is taken into account when we think about implementing these programs. And so one of the major concerns is that if we provide syringes and needles, they will be used as weapons. A positive thing to know is that these programs have existed since 1992, and there has not been a single reported incident of a syringe being used as a weapon. So that's reassuring. Another thing that people worry about is increasing needle stick injuries due to having these supplies more available. But actually, when they've studied this, they've found that needle stick injuries actually decrease after implementing these programs, as the needles no longer are contraband. People don't feel they need to hide them. They can have them out in the open, and then needle stick injuries are decreased. Another concern is that if we provide these supplies, that it might increase the amount of people that are using drugs or lead them to starting drugs while they're in prison. But there's absolutely no evidence that the availability of sterile syringes in prisons leads to more injection drug use. And the reality is that people are injecting and they're sharing within prison. And we really need to provide a program to be able to support these people so that they don't have to do that. Another concern is that if we're providing sterile needles in prison, we're admitting that there's security and screening failure and that drugs are prevalent. And so, as I listed off before, bleach is already offered within federal corrections as a harm reduction supply. And so they are acknowledging that people are using substances within prison. And it's unlikely that even the best efforts can completely eliminate substances within prison. And so we really need to focus on harm reduction. And so just a few take-home points about prison needle and syringe programs. We know that they reduce high-risk behavior and infections. They do not increase drug consumption or injection, and they have not been shown to endanger staff or prisoner safety, and they actually have been shown to reduce needle stick injuries. And these have been successfully implemented around the world, and it's likely something we should adopt more broadly within Canada and BC. So Correction Service Canada implemented the first needle and syringe program in June 2018. But the model that they've used is that people have to, I believe, approach a healthcare provider, and then they have to get official approval of the warden of the correctional facility to be part of that program. So not anonymous at all. And some of the recent data has shown that there's been a very low uptake of this program, and people actually are turned down often. And so really, it sounds like it's not acceptable to the people that need it. And I really think we need to advocate for expansion and improvement of these programs within Canada and BC in a manner that's acceptable to the people that require it. An overdose prevention site was recently introduced in Drumheller Institution, which was one of the facilities that had the highest rates of overdoses. And so it appears that this overdose prevention site is actually being used, but it was also implemented basically instead of a needle and syringe program. And so there may be people at those facilities that would benefit from a needle and syringe program as well. So lastly, I wanted to talk a little bit about how we can best provide support to people upon release. We know that the time of release is very high risk, and people are often discharged with minimal supports into the community. And it's very common for people to feel very isolated And this is reinforced by both informal and formal discrimination for getting jobs, for getting housing, education, and being accepted back into the public and their families. Primary care ends up being often the first point of contact for these individuals, and continuity of care between corrections facilities and the community can be extremely challenging. And often primary care providers might feel uncertain about how they can best provide care for these clients. So the Collaborating Center for Prison Health and Education has these excellent guidelines for family physicians, but likely could apply to any healthcare provider for working with people that are formerly incarcerated. Something important to note is that formerly incarcerated individuals may have had negative experiences with healthcare in the past, so it's important to take that into account when we're providing care for them. So we should approach this in a patient-centered, trauma-informed, culturally safe manner and include harm reduction as well. So just briefly to go over trauma-informed care and what exactly that is. Basically, it's recognizing how abuse and adverse events in someone's life can impact development, relationships, and behavior. And we should not be asking about trauma outright when we're just getting to know someone, but we should treat all patients with a trauma-informed practice approach, as we never know who has experienced it. Other things we can do to reinforce a trauma-informed approach is try to minimize the power imbalance between providers and patients, making sure we're asking permission and informing clients before we're doing something, trying our best to promote trust and a non-judgmental environment. And a key part to that is providing patients with control and choice in each and every encounter. Some other things that we can do is trying to promote continuity of care by asking for consent for release of the prison medical record. So all you have to do is send a fax or a letter to the facility that they were released from, and then you can have their record sent. And then making sure that we're helping support these individuals getting any reintegration needs that they have, like getting ID or medications or coverage or getting on social assistance or disability benefits. Making sure that we're accounting for what these individuals are at high risk for and screening appropriately. So things like mental health issues and substance use disorders. Making sure we're taking a complete sexual health history and being aware of possible sexual traumas that people have been exposed to in the past. Another important thing is making sure we're discussing reproductive needs, as sometimes these things get lost. And then making sure we're focusing on harm reduction. So overall, when we're providing primary care for people that are formerly incarcerated, we should make sure that it's trauma-informed, non-judgmental. We should make sure that we're aware of the risk factors that these people, that's associated with incarceration, and we should make sure we're screening appropriately. We should also make sure that we're assisting clients and connecting with community supports. And community transition teams might be a good method in which we can improve coordination of care within the community. So in conclusion, many of the patients we see as addictions providers are involved within the correction system at some point. It appears that management of substance use disorders within prisons, in particular in BC, is improving, but certainly there's still work to be done. And really, we must strive to help improve care for these vulnerable individuals. I just want to acknowledge a few people that helped me with this talk. And that's it. Thank you.
I think Allison's happy to take some questions now from the audience. Any questions? I can start off with, I've got a ton of questions.
Okay.
With one. We've focused on opiates here. I don't know what the uptake of other substances is in setting, particularly alcohol, maybe GHB and stimulants. Can you comment on that?
So the question was, are other substances being used within prisons, such as GHB, stimulants, and alcohol? And so I don't have any of the numbers on that, but certainly there are people that are sometimes brewing their own alcohol within prison, and stimulants are certainly available. It sounds like GHB, I'm not sure what the prevalence of that is, but it sounds like many substances are available within corrections across Canada.
And perhaps prescription meds as well. And perhaps you'd like to comment on the diversion risk of Suboxone, in particular in prisons. How high is that? I hear that it's pretty high. And why is that so?
Yeah, so the question was, what is the diversion risk of Suboxone, and why might that be that the diversion risk is high? And so, I mean, Suboxone is a very safe opiate agonist therapy that we use, and certainly it sounds like it's being diverted frequently within correctional facilities, and probably it's being diverted because people are using it to treat their opioid withdrawal. And so perhaps if we could titrate people faster and improve access to opiate agonist therapy, it'd be less of a problem.
Hi, thanks for that. I work at Legal Services. We're a legal aid clinic for all federal and provincial. It's a huge issue for us, both federally and provincially. And I agree with everything you're saying. We've seen a huge improvement since the health authority took over in BC corrections, and we've seen some improvements in federally in the prisons in BC as well. There used to be really, really long waiting lists for people who've been on the waiting list for a year for OAD in federal corrections. And that's improved a lot, although I understand there's still waiting lists in other parts of the country. One thing I was wondering is, I heard somebody say recently that they're worried that giving out so much Suboxone and increasing the use coupled with diversion means that prisoners who didn't have opioid use disorder before are developing it from using diverted Suboxone. And I wonder if you think that's a real concern. So how much concern, especially compared to obviously the other concerns people with the opioid use disorder using it.
Yeah. So I believe your question is, are we creating new opioid use disorders within prison, given if we're being too generous with the Suboxone, or perhaps not assessing people completely to diagnose them with an opioid use disorder? Is that correct? And so, yeah, I mean, certainly that is a possibility if we're kind of we're swinging too far to the other side by being overly generous with access to Suboxone and not providing complete assessments to decide who actually needs it. But I think another important thing to note is that there are underlying reasons why people are seeking out substances, whether it be Suboxone or whether it be other things. And so perhaps trying to focus more on the psychosocial treatments within prison might be helpful to allow people not to feel that they need something.
I'd just like to comment here that now that we have access to long-acting injectable buprenorphine in the form of Sublocade, this is going to be a great help, particularly in the correction setting, I think, because it takes away all of the concerns with diversion and it takes a lot of time away from the staff. One of the problems with Suboxone in prison is that normally it takes up to 10 minutes to dissolve to watch a dose. So that's one of the reasons why it's diverted easily, I think, is that staff just do not have time, especially when we've got like 30% of people on opiate agonist therapy to watch everybody, and time is of the essence in these kind of healthcare settings within prisons. So Sublocade is a once-a-month injection. It's less stigmatizing for the prisoners because people, you know, other guards and things aren't necessarily going to know that they're even on it because they're not going every day down to the dispensing clinic to have their dose of Suboxone. Yeah. And I think there's a lot of diversion, and perhaps not just for people to treat their own opiate withdrawal symptoms, but just for something to do, right? It's so we do see, I think, a lot of that recreational use by crushing and snorting the Suboxone rather than taking it sublingually. Yeah. So I think Sublocade is going to be a good option going forward. And I know that there's already programs in place studying this, and certainly has been in Australia with good outcomes in their setting. Jen?
I'm wondering, since we're on topic of Sublocade, what doses the offer?
So I mean, I think there's basically 2 standard doses for Sublocade. How it's been recommended to use is you do 1 injection of 300 milligrams, and then you do another 300 milligrams 1 month later, and then you decrease to 100 milligrams every month after that. And I think that's supposed to be around equivalent, somewhere between 16 and 24 milligrams of Suboxone sublingually. But I don't think Sublocade's ever really been studied in a scenario like we're in with these high potency substances. And so I think typically what's being done in the community is not lowering the dose at the 3rd month to 100 and just continuing on with 300. But it's a new drug that we're using within Canada, and so we're not really sure yet what the best thing will be.
My other question was, Gertie House, that's in BC?
Yes, it's on Vancouver Island, and it's connected to Nanaimo Correctional Center.
And what is the criteria?
Ooh.
And the wait list, how it-
Yeah, so I actually can't answer that question for you, but certainly I'm sure there's information online about it, but I've never actually been there. It's just something that I stumbled upon in my research and found really interesting. Yeah. Mm-hmm.
Thank you for your talk. So you kind of brought up the issue of acceptability of services and anonymity in the midst of that. And I'm thinking just in terms of like syringe disposal, that could compromise people's anonymity and bring extra scrutiny on them and such. I'm wondering if there's any models that you're aware of that are kind of trying to address that or trying to minimize the negative ramifications of that.
Mm-hmm. So it sounds like your question is, there might be concerns about people disposing these needles and then not being anonymous if they have those supplies on them. I mean, I guess one of the models, the syringe dispensing machine, where they're trading one for another, could maintain the anonymity as long as the machine is placed somewhere that's accessible and discreet. So that's probably one of the better models. Otherwise, the other models involve actually passing it on to someone else, whether that be a healthcare worker or a peer worker in the prison.
Yes.
I was surprised when you said that a lot of people will try to get into the needle exchange programs are down. They don't qualify or wondering what that might be or what's the.
Yeah, so I mean, Federal Corrections hasn't really released a lot of information because this program is quite new. But it sounds like they have some limitations based on whether people are violent offenders or have behavioral concerns within the prison. I think that would probably be one of the major issues that would limit someone from joining the program.
Thanks for that question. Any other comments or questions for Allison? No? Okay, that was excellent.